Great. Well, I'm absolutely delighted to be introducing Dr. Douglas White, who is visiting us today from Pittsburgh. So Dr. White is Vice Chair and Professor of Critical Care Medicine at the University of Pittsburgh School of Medicine, where he holds the UPMC Endowed Chair for Ethics in Critical Care Medicine. He directs the university's program on ethics and decision-making in critical illness, which is the first program in the country focused on ethical issues in critical care medicine. Dr. White graduated summa cum laude from Dartmouth College in 1995 with a degree in English literature. He received his medical degree from UCSF and was elected to the AOA Honor Society. Also at UCSF, he completed a residency in internal medicine, a fellowship in pulmonary and critical care medicine, a master's in epi and biostats, and a fellowship in clinical ethics. Dr. White's scholarship focuses on developing interventions to improve surrogate decision-making for incapacitated, seriously ill patients. He's been continuously funded by the NIH since 2005. He's published more than 200 peer-reviewed articles and has received numerous awards for his scholarship, including the Grenvik Award for Ethics from the Society of Critical Care Medicine and the Distinguished Research Mentor Award from the University of Pittsburgh. He's an elected member of the Hastings Center, the American Society for Clinical Investigation, and the Association of American Physicians. And on a personal note, I want to just say that he's just really very thoughtful and just a joy to have in our research world. And I would encourage all of you to, run your research ideas by him and try to meet with him while you're here. So welcome.
Wonderful, thanks. That's such a nice introduction, and it's wonderful to be here, see lots of familiar faces that I haven't seen in a while. Okay, so let me make sure I have all my AV needs sorted out here. Great, so today I'm going to be talking about the topic of integrating palliative care and critical care in adult intensive care units. These are my disclosures, none of which pose a conflict with what I'll be presenting today. And basically what I'd like to cover are three main things. First, I'll summarize problems that arise in ICUs related to patient and family-centered care. Second, I'll make the case that the way that we've been thinking about improving outcomes is flawed or at least insufficient. And then third, I'll discuss both primary and secondary or primary and specialty palliative care interventions, which I'll define as a path forward for improving patient and family outcomes in ICUs. So I think most, if not everyone in here, knows that the ICU is an incredibly challenging place for lots of people. 5 million Americans end up in an ICU every year. 500,000 Americans die in or shortly after an ICU stay. And we know lots about the challenges that arise. Patients experience distressing physical symptoms. Surrogate decision makers experience huge amounts of psychological distress, right? Often these are loved ones seeing their family member in incredibly dangerous and scary situations. We know that there are often communication breakdowns that give rise to distrust and conflict. And then many of these decisions, particularly around limiting life support, withholding or withdrawing life support, are incredibly ethically challenging, that both for families and for clinicians. And so this is I would say, the crucible in which many of us find ourselves. And we know also from lots of research over the last several decades that there are at least three interrelated problems in ICUs. First, ICU care is frequently misaligned with patients' values. In general, patients who die in ICUs or near the patients who die in the hospital setting often receive more invasive life-prolonging treatment than they would choose for themselves. Second, the process of being a surrogate decision maker for an incapacitated patient is incredibly distressing for the family members, and work by David Wendler and others have shown that surrogate decision makers have substantial regret about the decisions that they've made, as well as long-term psychological distress. And then finally, this is an incredibly expensive endeavor that we all find ourselves in. $82 billion spent on critical care in 2005. This is the last publication that I'm aware of, and this is 0.66% of the US GDP just on critical care services. So lots of reasons, both at the patient and family level, as well as the societal and structural level, to make sure that the care that we're providing is aligned with patients' goals. And so some of you, particularly those who geriatric focus, which I know is a great focus here at Yale, might be saying to yourselves, listen, this is, you've already lost me because you're focusing on this in the ICU setting. And I entirely agree that there's a huge amount of work that needs to be done upstream from the ICU for better advanced care planning. You know, this could be in the outpatient setting where clinicians are engaging with their patients when the patients have capacity about their values and preferences. And then also our colleagues on the hospital wards and in the emergency departments engaging with patients and families when patients are admitted to the hospital, when they still have capacity and before they cross the threshold of the ICU. All of that needs to be done, but it's not the case that that will make this problem go away. And work from Terry Freed here at Yale has, I think she's done some of the nicest work to articulate the values and preferences of seriously ill patients about intensive care and advanced illness. And so basically now, more than 20 years ago, Terry interviewed New Haven residents who were over 60 and had a variety of life-limiting illnesses and put to them a variety of scenarios and asked them, you know, would you be willing to accept X, Y, or Z kind of treatment? And the one that was most compelling to me is that she found that 86% of this very sick cohort, seriously ill outpatients, would accept a month-long hospitalization, including ICU care, including, you know, all of the things attendant with that, for only a 50% chance of survival. So that means, you know, 86% would take that gamble. Those are not people who you engage them in the outpatient setting and they say, you know, I don't want to go to the ICU. Let's just complete the advanced directive and that'll keep me out of that situation. Patient-centered care in these circumstances involves admission to an ICU for trying to get the patient through it. And if it doesn't work, as more likely than not, or equally likely it won't, then a transition to comfort-focused care would ensue. What this means is that these decisions continue to be things that critical care needs to focus on because many patients want a chance at survival, even if there's a good chance it won't work. All right, so thinking about that, then what has happened? What has the field done? And what I'd like to do is take you through a few studies, some of which are, I think, really seminal studies in the field, and also that give an insight into how we as investigators and clinicians have thought about what needs to change. So the support trial, how many people here have heard of the support trial? Yeah, that breaks down about what I'm seeing. There are a few folks who are on the younger side have heard of this. This is, in my view, one of the most amazing health services research studies ever done. It was almost 5,000 patients, and this is done now. What is that? That's 25 odd years ago. A cluster randomized trial before cluster randomized trials had even been described of seriously ill adult patients in the hospital setting, including in the ICUs, in which patients were randomized to either usual care or to an intervention that is largely focused on two things. First, that physicians in the intervention arm were given model-derived prognostic estimates of the patient's likelihood of 6 months survival, as well as their likely outcomes from CPR and their likelihood of functional disability at 2 months. And then second, a specially trained nurse called the support nurse went around to patients and families and elicited the patient's preferences around the use of life support in their current circumstances, and then shared that information with the clinical team. So this is what the intervention was. This happened, you know, in the intervention arm, 2,500 patients, really a truly remarkable undertaking. And the intervention was entirely ineffective on the outcomes that they looked at. And this is the slide from the JAMA paper. No difference in the time until a DNR order was written. No difference in DNR agreement, which is to say, did the doctor actually know what the patient wanted their code status to be? No difference in dying in an undesirable state, which is either in an ICU or unconscious in the hospital setting. No difference in pain control, and no difference in resource utilization. So this really remarkable undertaking done by largely some of the smartest decision scientists and health services researchers in the world just didn't work. And so you have to think a little bit about why not. And when you really dig down on the conceptual underpinnings of the support intervention, it was grounded in what's called the rational actor model or expected utility theory. And the idea here is that giving accurate information to patients or surrogates about the likely outcomes of treatment, as well as the patient perceived value of that treatment, will reliably lead to optimal decisions, which is to say they're utility maximizing and rational decisions. That's what the support intervention really was grounded in. And so when you think about what this would translate into as in terms of how clinicians would behave and how we carry ourselves and how we counsel families, I think that it sort of comports with what the standard view of many clinicians is, which is to say, you know, I've done my job. If I've made sure the family understands the patient's prognosis, the patient's values, and the treatment options, if they know that they're supposed to make decisions according to the patient's preferences, not their own, then good decisions will reliably follow. Well, you might say, okay, listen, the support trial 30, 25 odd years ago, things are really different now. A pure information-focused intervention delivered in a better, more modern way will be successful. And so this is a study that Chris Cox led that I and a number of other colleagues around the country were involved in which we developed a very modern decision aid, web-based decision aid, user-friendly, written at a 6th grade level. And we randomized patients in 13 US ICUs to either receive the decision aid, or their surrogates to receive the decision aid or to usual care. And these are all patients who'd been in an ICU ventilated for at least 10 days. So the so-called prolonged mechanical ventilation patient. And the decision aid took people through model-derived prognostic estimates of their likelihood of survival to a year, as well as the hospital discharge. It laid out different options for care, full intensive care, full comfort focused care, and a time-limited trial. It took families through a careful values elicitation exercise, and then it gave families some tips on how to communicate with the clinicians about the patient's values and preferences. So again, a fairly rational actor, logical, information-focused intervention. And this intervention also was entirely ineffective. So no effect on ICU length of stay or overall healthcare utilization, no effect on decisions to transition to comfort-focused care, no effect on surrogate psychological distress, which was high at 3 and 6 months. And interestingly, although surrogates got very clear prognostic information delivered in low numeracy friendly formats, no increase in the accuracy of their prognostic expectations. And in fact, what we found was that surrogates were extremely overly optimistic about the patient's chances for 1 year survival, despite what information they were given in the decision aid. And they favored much more aggressive treatment pathways than what they thought the patient would choose for themselves. So that's telling you that there's something else going on other than a purely informational problem with how these decisions are made. And interestingly, this flies in the face of a huge amount of literature from other domains in medicine showing that decision aids for patients facing treatment or screening decisions are incredibly effective. And so this is a Cochrane review, 105 different studies, more than 31,000 participants. The gist of the conclusion is across a wide variety of decision contexts, people exposed to decision aids are better informed, clearer about their values, and have more accurate risk perceptions. And there's growing evidence that decision aids may improve values congruent choices. So I'm just going to stop here for a second. Any ideas about why in the critical care context, information-focused interventions have not been effective, whereas they have been effective in other domains in medicine? Yeah. Okay, great. So it's an emotionally charged environment and people may be worse at processing information. Okay, what else? Yeah, the stakes of the decision are higher, life or death. I'm assuming that folks can't hear that. Is that right? Okay, yeah.
It's that context of withholding versus withdrawing something. So if you've already made the decision to pursue a critical care environment, then you're already down that pathway to switch that track. It's amongst different tasks and perhaps other decisions that.
Yeah, so something like a sunk cost bias or a cascade effect going on there, that this is a therapy that's already been initiated, maybe combined with the fact that it's so emotionally valent and psychologically difficult, might make it even harder to make decisions despite good information.
It's also the time and context. But where else do you meet somebody for the first time, have a meeting, let's say on the night of admission, and 15 minutes later you have to make a decision?
Yeah.
Right. Like, I think almost every other context you can clinic and come back a month later.
Yeah. So significant time pressures. Yeah. Yeah, right. The absence of a trusted physician, significant time pressures. And then the other thing I'll add, a couple slides I want to add, show too. Most of these decision aids are patients making decisions for themselves. And this is about almost exclusively about surrogate decision makers making decisions for their loved ones. And these are decisions to essentially often to let them die. So let me just, I think you guys got it all, basically. Let me sort of package it in slightly more academic terms though. So on this issue of emotion, there is a huge literature that people in what I think of as hot states, right? You're flooded, many of you have felt this in fights with your partner or whatever, you become a little not particularly rational, your cortex turns off, your amygdala lights up, your reptilian brain is going in overdrive. And what that looks like when you study how people make decisions is that people in those states have lower ability to recall information. They select options in these choice studies without really considering the alternatives. And then this jargon of they process persuasion arguments less thoroughly. A persuasion argument is essentially what doctors do when they try to counsel families that now might be the time to focus on comfort rather than life extension. That's a persuasion argument. And the data suggests that when people are in hot states and their cortex is turned off, they don't really hear those persuasion arguments effectively. So that's definitely one part of it, this notion of emotional overwhelm. And obviously, a pure fact-driven intervention doesn't attend to that. The other is what the left wing of the auditorium raise, which is this is not just any old medical decision. These are incredibly existentially challenging decisions being made by a loved one for their loved one. So it's not that they're making a decision for themselves, they're making a decision for someone else. And we know from a variety of studies that I've listed here that even when families have very clear information about the likely outcomes and understand the options that are available to them, they experience significant emotional conflict between the desire to act in accordance with their loved one's values and their own personal desire for not wanting to feel responsible for a loved one's death, and also a desire to pursue any chance of recovery. So there is a bias toward more treatment. So many surrogates feel a bias toward overtreating because the cost, the psychic cost of undertreating is far greater to them than the psychic cost of overtreating. All of these things, I think, are the kind of things that make the decisions that we routinely encounter in the ICU setting much more difficult than the average medical decision and probably much more resistant to information-focused interventions. And so with Nick Dion Odom, we wrote a piece in JAMA now a couple of years ago in which we proposed that we really need to rethink and rejigger how we're supporting surrogate decision makers in the ICU context. And we argued that rather than this, sort of simplistic rational actor model of cognition leading to decisions, we need to broaden that framework, and that we need to think about decision support more broadly, which is to say decision support that focuses on medical facts alone mistakenly treats the act of deciding for others as a purely cognitive exercise rather than one that also entails emotional and psychological dimensions. And so if we're thinking about really rigorous decision support, it's not only the information that families need, it's emotional support and attending to the psychological difficulty of acting as a surrogate for someone else. So one way to think about this is integrating various elements of specialty palliative care into intensive care. And what I'd like to do next is just take you through a little bit about what is specialty palliative care and what data or lack of data do we have on whether this is effective. So many of you know specialty palliative care, and this is a definition from the Center to Advance Palliative Care. This is specialized medical care for people with serious illness. It focuses on providing relief from the pain, symptoms, and distress of a serious illness. It's a team-based approach, and by determining patients' goals of care through skilled communication, treating symptoms, and coordinating care, palliative care teams meet patients' needs and help them avoid unwanted and expensive crisis care. Palliative care is not hospice. Unlike hospice, palliative care can be provided at the same time as curative treatments. It's appropriate at any age and at any stage. So this, when you look at this, and then I've also listed here the main domains of high quality palliative care, this seems to line up pretty nicely conceptually with the main barriers or challenges to good patient-centered decisions in the ICU. Okay, so my next question for you guys, if you are thinking about doing the studies to say, all right, I wanna do a randomized trial, and convince policymakers once and for all whether specialty palliative care works in the ICU setting. What would constitute working? So what outcome measures, or it doesn't even have to be in a fancy way, but like, what are the things that you'd like to see improved that would tell you and tell policymakers that palliative care is effective in this context?
Can I just ask just a broader question? What you described feels to me like what we should be doing for all of our patients, right? As palliative care, right? Providing pain relief, providing emotional support.
Don't steal my thunder. Don't steal my thunder. Yes, we'll get there. That's called primary palliative care. But yeah, we'll get there. Let's think about it. Just think about it in the context of what you'd hope to see from an intervention. Yeah.
Positive patient and family experiences of the ICU stay.
Okay. So they feel satisfied or well supported, something like that. Okay.
Trust care of the team
Yep. They trust the team. Because you went first, I'll ask you the hard question. Would that be enough? If that was the primary and sole outcome in a big trial, would that be enough for hospital systems around the country to scale up their palliative care services and deploy them? Yeah.
I think if it's for it to be implemented, you probably want to see that you're reducing ICU lengths of stay.
Okay. All right.
Affecting a lot.
So now you're thinking like a CMO or a CEO. Okay. So there's some money and utilization things too. Okay. What else? Anything else?
Alignment between patient preferences and care delivery.
Yeah, so something about, if the claim is that, so you just said alignment between patient preferences and care delivery. So something about achieving what we think of as goal concordant care, that rather than patients being over treated at the end of life, that there would be some measure, whatever that measure is hard to discern, that suggests that the care seemed to more closely align with what was important to the patient than in the usual care arm. Okay.
I think quantitative outcomes are important, like for example, pain scales or other quantitative measurements that can actually be gauged, like for example, to expanding off that point, maybe family satisfaction, a quantitative objective.
Yeah. So pain control as one measure, but yeah, right. If we're trying to palliate patients, they should be palliated. Their symptom burdens should be lower than in the usual care arm. Yeah.
The rest of the things, or the quantitative measure for angst is a little bit different from the alignment with the patient goals, because like we showed, they may not always be
Yeah.
in a good state, even if they feel like they're.
Yeah. So psychological distress. Families may be peri-traumatic distress. That's the conceptualization for the distress they feel in the moment, and then also their longer term anxiety, PTSD, depression. All right, last one. Yeah.
Thinking about one of the biggest opportunities we had in trials, really interesting. You can document no difference or improve things at mortality.
Yeah.
Just thinking about
Right.
groundbreaking trials in palliative care.
Yeah. Ooh, let's come back to that one. But yes, at a minimum, you'd like to see, you need to know what's the impact of this intervention on mortality, because there's an open question about whether higher mortality is a good or bad outcome, and it really might be contingent on the patient's values and preferences. But yes, so you might need to think about a multi-attribute outcome measure. Let me keep going because I want to get through the slides, but we'll have time to continue to unpack this. So I think you guys hit them all here. Patient level outcomes, goal concordant care. We'd like to see function and symptom control, family outcomes, both peri-traumatic distress and longer term outcomes. I would like to make sure that surrogate decision makers are understanding the prognosis as they're making decisions, that they feel clear about the patient's values and preferences, that the care is patient and family centered, and then all the utilization outcomes. One thing we didn't talk about is it's possible that having palliative medicine consultants involved might decrease the number of really vexing cases that we as clinicians experience, and decrease our moral distress and job strain kind of over time. So you think about a unit level intervention that has an organizational effect that's hard to measure at the patient level, but is measurable at the unit level. Okay, so then what are the data that we have around the value of palliative care consultation in ICUs? Well, so Randy Curtis and Judy Davidson in 2017 led the guidelines for family-centered care in the neonatal, pediatric, and adult ICU. And on this question, here's their summary of the evidence. There are limited data, including 5 very low to low quality studies that suggest that proactive consultation of palliative care services decreases ICU and hospital length of stay among certain patients. And these are the particular patients: advanced cancer, advanced dementia, coma, post-arrest, ICH with mechanical ventilation, et cetera. That's the outcome measure. Of the 10 or 15 you guys just named, we have data on length of stay and maybe a little bit on costs, but we have only quasi-experimental studies, which is to say no randomized studies of this. And they've all been small. They've had pretty inconsistent results, and they haven't assessed the outcomes that you all have just said are important to patients, families, and policymakers. So that's a fairly problematic evidence base in my view. And so Rebecca Aslickson nicely wrote an editorial that even predated this one in 2014. She and colleagues said the field could benefit from a definitive, well-powered, well-designed, multi-center controlled trial evaluating proactive palliative care in the ICU as compared to usual care. So well said. I entirely agree. But what about, someone I think mentioned or was alluding to this notion that we know that specialty palliative care works in other disciplines, right? So Jennifer Temmel and colleagues have done a number of studies now that show that early palliative care for patients with metastatic non-small cell lung cancer and other cancer improves a number of important patient level outcomes. I would just make the argument that it's a really different beast to do palliative medicine in the ICU than it is to do palliative medicine in this study. And the main reason is that the primary recipient of structured palliative care or specialty palliative care in the ICU is typically the family. In the outpatient setting, it's the patient. In the inpatient setting, it's the family or the surrogate. In the it's delivered, the palliative care is delivered in the outpatient setting versus inpatient setting. And this, the data we have are from a palliative care consultation that played out over weeks with weekly visits by a highly trained palliative medicine doc, rather than the days or hours that we often have in the ICU setting. So I don't think the claim that the Temmel study addresses this is really one that holds much water. But since that piece by Judy Davidson and Randy Curtis, there is one study that has been added to the literature. This is done by Jessica Ma and colleagues, published in 2019. It's still a quasi-experimental design. It was a single center, what they call the cluster randomized trial, but it was basically a pre-post study in 2 medical ICUs at WashU. They studied 199 patients who met one of the kind of conventional palliative care triggers, all of which I've listed here, indicating a high risk for morbidity or mortality. And as you look down this, I think these are fairly reasonable triggers if you're looking at what we call disease-based triggers, coming from a skilled nursing facility, having advanced or end-stage dementia, ALS or Parkinson's, metastatic cancer, coma, post-cardiac arrest, et cetera, et cetera. These are sort of the standard disease-based triggers. And what they found is that in the palliative care arm, there were higher rates of DNR, DNI status. There were more transfers to hospice, fewer tracheostomies, and less post-discharge hospital readmission. But interestingly, no effect on ICU or hospital length of stay, no effect on total hospitalization costs, no effect on hospital or 30-day mortality. And then I think arguably many of the important outcomes were not measured because this was not a study that did patient and family outcome follow-up. So we are still really left with a very thin evidence base about whether palliative care works and in whom. And that really set the stage for a trial that we have ongoing now. This is called the PROPACT trial, a trial of integrated specialty and palliative care for critically ill older adults. This is funded by the NIA. The results are not, the trial is ongoing now. We're enrolling 500 patients. We have enrolled about 375 so far. So we hope that in the next year, we'll complete enrollment and get this thing published. But it's a patient level explanatory randomized trial. And if you come to my talk tomorrow, we'll talk more about explanatory versus pragmatic trials. But this is meant to deliver specialty palliative care with very high fidelity, so a tightly controlled trial. We're doing this at 5 hospitals in Pennsylvania. And essentially, the intervention involves very early integration of the specialty palliative care team, co-managing patients in the palliative care domains alongside the critical care service. And so the content of the intervention, which we've pretty highly protocolized, is that the palliative care consultation needs to come from someone who is a board certified palliative medicine physician. Family meetings need to happen within 48 hours and at least 5 days thereafter and be attended by both the ICU team and the palliative care team. The palliative care team will visit the patient and family every day, also check in with the ICU team every day and make decisions about care plans in the shared domains of palliative care. And then finally, when the patient leaves the ICU, if they survive, to engage in advanced care planning to attend to future medical decisions. And so I don't know if this is readable to you all, but these are the outcome measures that we're looking at. And we really tried to hit all the domains that we just talked about when we talked about what's important to assess. Patient-centeredness of care, families' post-traumatic stress symptoms measured at 3 and 6 months, anxiety and depression among family, a variety of patient outcomes, including hospital survival, survival through 6 months, days alive and outside the hospital, which I think is an important patient-centered metric, functional status, a measure of goal concordant care. And I will say this is a very tough construct to measure because there is not currently a single well-validated instrument. So we're using a composite measure for that. And then we're also measuring a variety of things related to whether families' palliative care needs were met during the hospital stay, whether the family understood the patient's prognosis when measured on day 5 and compared to the clinician's estimate, and then whether the surrogates felt that they had good clarity about the patient's values and preferences, along with, again, measuring a lot of healthcare utilization outcomes that would be important to hospital administrators and policymakers to understand the value proposition for any benefits that come from palliative care consultation. So that's ongoing. I am not personally optimistic that this will be a panacea, even if the trial is effective and shows that palliative care is effective. And the reason is, simply put, that there are just not enough palliative care specialists across the country to staff up ICUs, and there won't be for decades, basically. And so Hannah Mehua and Hannah Wunsch did a really nice study in which they estimated the number of patients across the country every year who would need palliative care consultation in an ICU using traditional disease-based triggers. And they found that between 1.1 and 1.5 million ICU patients per year would meet the disease-based triggers. And quote, that is a need that is unlikely to be met by the existing workforce of specialized palliative care providers. And that's if every FTE was devoted to the ICU setting. Right now, we know about 0.3, about 30% of palliative care clinicians' time is in the ICU setting. That would require shifting all of it to the ICU setting. And then similarly, ASCO recently, the American Society for Clinical Oncology, recently came out with a recommendation that recommends palliative care consultation for all patients with advanced cancer, which would require more than a doubling of the existing FTE of all palliative care specialists. So that would be taking the 30% in the ICU and moving them all to the oncology space. We have a massive shortage of palliative medicine clinicians. And so I think it's important to know whether and in whom palliative medicine consultation might be effective, but I don't think it's going to solve things. So this gets back to what you were raising, this issue of integrating primary palliative care into intensive care. And I want to just take you through conceptually what that is, and then 3 different studies to quickly touch on that show different ways to integrate primary palliative care into the ICU setting. So the idea behind primary palliative care is that the core components of palliative medicine are delivered not by a palliative care specialist, but instead by the interprofessional ICU team. And so basically what's listed here are the kind of things that would be expected to be done by the interprofessional ICU team as primary palliative care: basic management of pain and symptoms, management of depression and anxiety, and then sort of what I would think of as run-of-the-mill or relatively straightforward goals of care conversations and code status conversations. And specialty palliative care would be reserved for situations in which essentially they're the hard cases. So management of refractory pain or other distressing symptoms, management of existential distress or more complicated depression, anxiety, and grief, managing severe conflict within families or between families, and then assistance with addressing cases of what we now call potentially inappropriate treatment, what used to be called futility. So that's conceptually what primary palliative care is. And there are a lot of different ways that can be organized. So, a really nice study that was recently done at UCLA gives one example of an intervention to skill up the existing ICU team to deliver at least some domains of primary palliative care. So this was a pre-post study. So again, a quasi-experimental design, non-randomized, in 3 medical ICUs in which 209 patients who are critically ill and judged to be at high risk of death were enrolled. Basically, the intervention involved was what would be called a complex behavioral intervention. Changing ICU care delivery processes so there are family meetings within 1 to 2 days of admission, putting all the physicians in the ICU through a communication skills training program to help them develop higher level skills for shared decision making, and then also integrating the framing of the ICU admission as a time-limited trial into how they frame the goals of care decision making with families. And so again, this was a study that did not engage patients and families in outcome assessment in the long term, but what they found is that this intervention was associated with shorter ICU length of stay, 8.7 versus 7.4 days, less use of mechanical ventilation, no change in hospital mortality, and no change in family satisfaction. So the way these authors concluded it was to say that this intervention did not worsen satisfaction, did not increase mortality, but did decrease ICU utilization near the end of life. So that's one example, really focusing on the doctors as the unit of intervention. Another, I think, really interesting study that was just published is a randomized trial, a patient-level randomized trial, so pretty good quality evidence of a spiritual care intervention on well-being of family surrogate decision makers. And this was done by Lexi Tork and colleagues at Indiana. This was a patient-level explanatory randomized trial in 5 ICUs at IU. And they randomized the surrogates of 188 incapacitated critically ill patients who are a reasonably sick group, 21% overall mortality, to either usual care or this semi-structured spiritual care intervention delivered by specially trained chaplains, 2 to 3 visits in the ICU with weekly follow-up, and then if the patient died, bereavement calls. The content of the spiritual care visit involved emotional support, supporting spiritual or religious concerns, notably religious concerns and prayer were part of less than 1 in 5 of the consultations. So this was very much a spiritual rather than a religious intervention, and then support of medical communication and decision-making. And so what they found, interestingly, is a very significant reduction in surrogate decision makers' symptoms of anxiety when measured 8 weeks post-discharge with the GAD-7. This difference exceeds the minimal clinically important difference. Also, a significant decrease in the patient's PTSD, or sorry, the surrogate's PTSD symptoms, no real change in ICU length of stay, and then a difference of almost 10% in the use of life-sustaining treatment with less use in the intervention arm, but a difference that did not reach statistical significance. So very, I would say, promising preliminary results that we are potentially under-leveraging our spiritual care colleagues in cases in which there may be spiritual issues at play or existential distress among surrogate decision makers. And then finally, I just want to end by presenting a trial that we did in the UPMC health system, leveraging what we think of as an intervention that involves the entire interprofessional team to deliver primary palliative care. And so we conducted a stepped wedge randomized trial comparing usual care to a family support intervention, as I said, delivered by the interprofessional team. We randomized 1,420 incapacitated critically ill patients who were at high risk of death or severe disability. We also obviously randomized their surrogates and pairing with them. And we studied a variety of different outcome measures. I'll explain the intervention in a second, but we looked at surrogates' long-term psychological distress, and the HADS, the Hospital Anxiety and Depression Scale, was the primary outcome. Measures of patient and family centeredness of care, ratings of the quality of clinician-family communication, and then the utilization outcomes of ICU and hospital length of stay, as well as total and direct hospitalization costs. So the intervention was really grounded in this cognitive emotional decision-making framework that we've already talked about. We picked nurses who are already in the ICUs, who already practice, who are viewed to be very much sort of the leaders in the ICU of family support, and we gave them advanced training, 12-hour training in advanced communication skills. We paired that with implementing a family support pathway that I'll show you on the next slide, a fairly protocolized approach with some flexibility to support families in the ICU. And then another part of the intervention was intensive QI or implementation support from a trained implementation specialist to essentially help the ICU go from whatever their wild type care was for family support to a reliable family support process. And so this is probably too small to see, but the idea is that the partner nurses engaged with the family from the very first day of ICU admission and framed their role as walking with them through the entire ICU stay, checking in with them daily, making sure that they're having meetings with the doctors, helping them get ready for those meetings, and then if any issues are coming up, helping make sure that they get in good contact with the doctors. So these nurses were really meant to be the safety net and the support for the families during the study period. They also took the lead on getting family meetings scheduled within 48 hours of ICU admission and then at least every 5 days thereafter. And then what the nurses did that I think was important is they also sat down before every family meeting with the family and walked them through an opportunity to sort of get their thoughts together. So the nurses said, what are the main things that you want to talk to the doctors about? What are your main concerns? And let's write them down. And they wrote them down right here. And then they said, this is what's called the question prompt list. And they said, these are the questions that families in ICUs often have. Do you have any of these questions or these things that you'd want to talk to the doctor about? And many of these are tough things for families to ask, right? What's my loved one's prognosis? How can I make sure the doctors know about my loved one's values and preferences? What are the different options that we should be thinking about? How can I know if my loved one's getting better? And then finally, there was an opportunity for the nurses to explain, so this is what the doctors will be telling you, but they'll also be wanting to get some information from you about your loved one and help them begin to think through what it means to be a surrogate and what might be their loved one's values and preferences around their current clinical condition. So that was the intention, that was the intervention. It was deployed with high fidelity. And what we found is that it had zero impact on surrogates' long-term psychological distress. So did not move the needle at all with depression or anxiety, or the IES is a measure of post-traumatic stress. No effect at all. But on every other outcome measure, the intervention had a positive effect. So higher ratings, significantly higher ratings of the quality of communication, and I think really importantly, significantly higher ratings of family feeling that the care was centered on the patient's values and preferences. So this is a wonky scale, but a lower score is better. And the easy way to think about it is that it resulted in about a 15% increase in the proportion of patients in the intervention arm with scores in the highest range on patient-centeredness. And we also did a careful economic analysis of the intervention. What we found is that it had a significant decrease in the length of stay, the ICU length of stay overall, but all of that arose in a shortening of the length of stay among patients who died, 6.8 days on average in the control arm, 4.4 in the intervention arm, and really no difference between length of stay and amongst survivors. It had a significant decrease in overall hospital length of stay. And then when we looked at overall total hospitalization costs, it was about a $6,000 decrease, and direct variable costs, which are the ones that actually matter to most people weighing the cost of an intervention. It was about a $2,000 decrease in costs in the intervention arm. And we also did a fairly careful cost assessment of the partner intervention and found that it cost, when you put all inclusive of the nurse's training time, the nurse's time in it to deploy the intervention above and beyond what they usually do, and then the cost of the implementation support, it was about $170 per patient. So I think about this kind of intervention and these results as the ethical and economic vectors both pointing in the same direction. Okay, so let me just end here. I want to make sure we have some time for discussion. I hope that I have convinced you, if nothing else, that this view is outdated. This view that says that my job as a doctor is to make sure the family understands the patient's prognosis, values, and treatment options. And if I've done that, everything's good. And instead, I hope that you'll replace that with a mental model or a mindset that is, when walking into the ICU, we need to emotionally and psychologically support the family through what is a traumatic experience and collaborate with them to make patient-centered decisions, which might involve deploying reliable family support pathways in the ICU, as we've talked about in terms of primary palliative care interventions, deploying interventions to skill up clinicians to have these hard conversations, and then developing thoughtful approaches to involve our palliative care specialists for the hard cases. And I will say that I think the jury is still out on which cases those are, but stay tuned on that. All right, thanks very much.
Is this on? Thank you so much, Doug. That was a fantastic talk, and the floor is open for questions. And I see that we have a hand over here. I will just ask you guys to please briefly introduce yourself and speak into the mic so Zoom can hear. Sandy and then
Sandy Zay, thanks for a fantastic talk. Quick question about the specialty intervention that you guys are doing right now with the integration of palliative care physicians. So is there some kind of standardization of the intervention? I mean, it sounds like you need to have a palliative care certified person that is initially meeting with the patient and their family and then like follow-up meetings. But is there like a standardization of what's being said? Are you hitting those like core metrics?
Yeah. Great question. So this is where this is one of the sort of challenges of the field. How much do you just absolutely prescribe what the doctors must do versus how much discretion do you give them to tailor what they do to their judgment about the needs of the patient and family? And in this case, what we have prescribed and what we've said is you need to do a full palliative care assessment based on the 5 domains of core palliative care. And then from there, it's really your judgment about how you intervene on both of them. So on all of them. So we didn't come up with, pain must be managed this way, existential distress must be managed this way. We left that to the discretion of the palliative care consultants. But that's why we required board certified palliative medicine specialists to say that, we're leaving this in the hands of people who are well-trained and thoughtful clinicians. What we did say, we did also protocolize that when you have family meetings, they need to happen at least this frequency, every, within 2 days and then every 5 thereafter. And the ICU team and palliative care team must meet together because we've seen that's been a limitation of prior studies where the palliative care team did what my wife is a child psychiatrist and she talks a lot about parallel play and sandboxes. The palliative care team is doing their thing and the ICU team is doing their thing and they may not be doing the same thing and that might be a problem. So we asked that they meet together. And so that's the sort of middle ground we found between prescribing and being very prescriptive and leaving their room for some clinical discretion.
Hi, Margaret Pisani. My question is kind of relates to the background, and I don't know if there's an answer for this, but do surrogates have the same distress if patients have advanced directives?
Yeah. So we've done a little bit of research on this, and we have found that decisional conflict, that's the main, and decisional regret, that's the main measure that you would look at to say, do they regret their decisions? In a large cohort of 1,200 patients, we did not find an association between the presence of a written advance directive and levels of decisional regret. But what we did find is that surrogates having the subjective sense that they understood their loved one's values and preferences, that was associated with less decisional conflict when making decisions as a surrogate. And I think that the latter finding is more important. It says, if the family feels that they have a good gist sense of what the patient's values and preferences are, it's going to be easier for them to make the decisions. If the patient has a piece of paper, it stands to reason that there are lots of reasons that piece of paper may not do much work, right? Number one, they may never have talked to the surrogate about it. Number two, most boilerplate advanced directives just address if you're in a coma, a PVS, or end-of-life situation, which is not really what comes up in the ICU setting. Yeah, I think it's a good question.
Thanks, Doug. Mark Siegel. So taking a step back, watching this area of research evolve over many years, it can't help but notice that the whole topic is driven by this issue of trying to get at values and decision-making as a primary outcome and intent of the work that we do. And yet I wonder if there's something to be learned from our palliative care colleagues in terms of how they approach some of these topics. So we have a lot of our palliative care physicians here today, and I have learned a ton watching them. And one of the things that I've noticed is that when they first do an intake with a lot of patients and families, it seems like a really open, curious, introduction that isn't necessarily driven by a particular outcome. I want to get to know you, tell me about your loved one, tell me your story, things like that. And it's almost like this implication, like whatever this leads to, DNR, not DNR, whatever, that somehow that's actually a separate goal.
Yeah.
And just sort of tie it into the observation that you made about spiritual care, there was a similar study done in the oncology literature, I think the Holly Prigerson's group worked on, where they actually provided palliative care to patients who had large spiritual needs. And in that process actually led to more people choosing less aggressive ICU care. So I'm wondering if we just almost need to put a hold on these intentional discussions and just say, okay, just give them what they need.
Yeah.
Make them feel listened to, and we'll see what happens after that.
Yeah, I think, Mark, it's a great question. It's a very operational question. I mean that in a good way, which is to say, it's when the doctor or the APP sits down with the family, should they say, we have some decisions to make about code status and whether to continue life support, and here are the options, and let's talk this through. And that, by the way, that's the decision scientist would say, yes, of course, you need to make sure that everyone knows there's a decision to be made, they know what the treatment options are, and they know what's at stake in the decision. And I tend to agree with you that a better approach in this very emotional, very psychologically charged place is to start with, what's important to your loved one? Had they ever talked about what was important to them? What are their hopes? What are their worries if they got this sick? And let a picture emerge of who the patient is as a person. And then the clinician can move from that to, based on what you've told me about what's important to your loved one, there are a few medical things that I think we need to do. And here's what I think is the right thing to do. Here's what I don't think we should do. Am I hearing it right? Like, does this resonate with you that this is the right way to go? And if, I think it took me a while to get there because I feel like I was trained primarily as a decision scientist to start, and there's a lot of risk of bias in that approach. If a physician comes in and really says, like, listen, here's what I think we should do based on what you've told me about your loved one's values, and it's an indeterminate set of values, and they sort of force it to be more what they want done. That's the thing that has made me nervous. But over time, I think I've softened on that. And I feel like we need to train clinicians to work against their own biases and to know that that's a risk of this approach. But I think the risk is even greater of keeping it in the sort of pure rational actor, like, here's the analytical situation we're in.
Yeah. It's more of a methodologic question, but you used the term explanatory randomized controlled trial a number of times in some of the study designs. I was wondering if you could clarify what you mean by, are you looking at mediating and moderating effects, or contrasting this with a pragmatic trial approach?
Yeah, so it's one way of conceptualizing clinical trials of complex interventions is along a spectrum from a very explanatory design to a very pragmatic design. A very explanatory design essentially is what you think of in the drug world as an efficacy trial, which is to say, under very highly controlled circumstances, does this intervention work? A pragmatic design is saying, in the real world, without much attention to trying to make sure the intervention is delivered per protocol, what is the effect of the intervention? And both can allow for mediation and moderation analyses, but they're easier to do when you tightly control the dose of whatever it is that you're delivering, so that you can, it makes for a cleaner analysis when you don't have all that between subject variability.
Doug, thanks. That was a great talk, Kathleen Atkin. I'm thinking about the specialty versus primary palliative care in the ICU, and thinking about what we need to do as intensivists to either harmonize the way that we care for patients and communicate, or have some continuity. Because I think that's the other thing that we're really undermining ourselves with, is having, different personnel every week, 5 days during the week, or someone else different on the weekend. And that's part of what I find the palliative care service, among the other emotional IQ and tenderness that's offered in the VA palliative care service, that continuity is really priceless. And so what can we learn from that in how we can improve our primary palliative care delivery in the ICU?
Yeah, You know, there have been some studies where, like again at Barnes, at WashU, there was a study in which they had a service for the high-risk patients that was where the attending and an APP were the same throughout. It's never been replicated, and I think it's largely never been replicated because it's like an entirely unscalable approach to provide ICU care. It's an interesting proof of principle, and it does support that was a positive study, and it supports the notion that the continuity is probably important. Of course, that's confounded by, you know, they picked the ICU director and a really skilled APP who are probably much better at these conversations than the average person. I guess, Kathleen, I might push back a little bit about whether palliative care reliably provides more continuity. It just depends on the palliative care staffing model, right? You know, at our institution, they're on for a week as well, and their weekend coverage is different. There are, you know, APPs or nurse practitioners or PAs that work more sort of banker's hours or business hours. That I have found to be a really valuable source of continuity. So I think there's a lot to be gained there, but I think palliative care teams struggle with many of the same issues around how do we make sure that for someone who's here for 17 days, that they see sort of the same face every day.
Ella Christoph, second year fellow. Looking at the different studies that have been variably effective and ineffective and the different providers that folks have chosen to use as the intervention, and you kind of have almost this spectrum of the clinicians, perhaps the doctors who are more rational actor oriented, and then you have perhaps the other end of the spectrum, the chaplains who are really spiritually and psychologically attuned. How do you think about an intervention where you're capitalizing on what someone is already good at and using that person in that role versus training up people who perhaps maybe don't necessarily want to let go of that responsibility of being the primary person?
Even if they're not good at it? Is that what you're driving at?
You said it.
Yeah, okay. I hear you. I mean, I think there's a real, right. So the risk of forcing a primary palliative care approach, or the risk of saying like, and I have been guilty of this, which is sort of thinking, you know, this is your job. Like if you're going to be an intensivist, this needs to be your job. And again, I've softened on that over the years. People have different aptitudes and different things that they really excel at. I do think there's a floor of ability to do this, but I share your concern that if we developed structures that forced the people who are not dispositionally good at it and maybe have not acquired the skills to do it more, that we could be worsening outcomes. And I think a really functional interprofessional team organically adapts to that. Like if you know the nurses in the ICU know which of the doctors are not good at this, and behind the scenes, they're talking with these families more than they would be if it's, you know, Mark who's on in the ICU.
When you have consistent staffing in your nurses.
Yes, true. Right. If they know, if they have the sort of the MO of each of the doctors in the unit. Yeah. And I think that we've certainly seen that fall by the wayside with the pandemic. That's true. Yeah.
Thank you.
Anyway, but for the people on Zoom, so for everyone, so it's after 4, so I'm going to have to end questions here, but I just want to highlight that Dr. White will be speaking again tomorrow at our research conference from 12 to 1 in TAC 447 for those of you here in person with lunch and also on Zoom. And for the fellows, there will be a breakfast tomorrow morning. So if you're not on that list and you wanted to join, just reach out. And thank you again to Dr. White for a fantastic talk.